Hello, and welcome to our first keynote session of our virtual summit, Perspectives on Health Equity with Dr. Rashawn Ray and Licy Canto. I am Catherine Martucci, Director of Policy and Programs at the Alliance for Health Policy. For listeners who are new to the Alliance, welcome. We are a nonpartisan resource for the health policy community dedicated to advancing knowledge and understanding of health policy issues. And the goal of this multi-part virtual summit is to explore the short and long-term impacts of the ongoing COVID-19 pandemic and its potential to significantly transform our healthcare system. And we want this to be an interactive discussion with our two speakers, so please get your questions ready. You should see a form to submit questions on the right side of your web browser that is labeled Submit a Question. And please send in as many as you would like at any time. We'll be collecting these throughout and addressing them during the broadcast. You can find all the materials that accompany this session on our website, allhealthpolicy.org. And finally, if you have any technical issues during the duration of the event, please click on Troubleshooting Tips/technical support that's in the bottom left-hand corner of your screen. Please join us throughout the week on social media by using the hashtag AHPSummit20. And feel free to ask questions, engage with us and each other after this event and as we continue the conversation online. And we're also going to be having events throughout the week, so tune back in tomorrow and Thursday for more panels, keynotes, and discussions. And if you miss any of the sessions, you can find recordings of them on our website. And now I'm honored to introduce our guest moderator for this keynote discussion on health equity. Licy Canto is an Executive Vice President and Managing Director in the BCW Public Affairs and Crisis Practice. He has over 25 years of experience at the international, national, state, and local levels, and across the nonprofit, philanthropic, corporate, and government sectors. And he works every day on healthcare and social impact policy and strategy, and helps shape strategic direction on diversity, inclusion, and belonging for BCW and its clients across North America. So be sure to read his full and very impressive bio in the handout materials. And Licy, thank you so much for being with us today and for lending your expertise to this summit. The virtual floor is now yours.
Thank you very much, Catherine, and thank you to Sarah Dash and the terrific staff and team and board of the Alliance for having such an important conversation today as part of your summit. I also want to welcome everyone who's joined us today for this virtual conversation. There are two crises that are convulsing our nation: the COVID pandemic and systemic racism. Together, they have brought to the forefront in brutal fashion the structural inequalities that have long existed in our country in so many facets of our lives and communities and in our institutions. Education is at a tipping point, the precipice of our time, I would say. And all of us are asking, have we finally reached the moment, the hour that will change our country now and moving forward? Lyndon Johnson said, history, faith, and justice come together at the right time, at the right moment. This is our time. This is our moment, not just to reduce, but to eliminate inequality, inequity, and injustice in our healthcare system and in so many other systems and corners of this country. So today I want to welcome you to what my friends in the South call a kitchen table conversation on health equity, healthcare inequality, and the path forward. As you may know, there are two types of conversations in the South: one that is casual, that happens out on the porch, and one that is brutally honest and direct, that happens in the kitchen. And today, I'm very glad to have with me at the kitchen table conversation the wonderful and fantastic Dr. Rashawn Ray, a David M. Rubenstein Fellow at the Brookings Institution. And Dr. Ray, Rashawn, as I will call him, is a professor of sociology and executive director of for applied sciences research at the University of Maryland. He's also one of the co-editors of Context Magazine, Sociology for the Public, and he has published over 50 books, articles, and book chapters, and nearly 20 op-eds. Most recently, Dr. Ray published a book on how families matter, simply complicated intersections of race, gender, and work with Pamela Broby Jackson, and another edition of Race, Ethnic Relations in the 21st Century, History, Theory, and Institutions of Policy, which has been adopted nearly 40 times in college courses across the country. The Alliance, of course, has highlighted many of these resources in the materials section of this webinar, so be sure to check out those for further reading on this critical topic. Dr. Ray, Rashawn, welcome. I'm so glad to have you here.
Thank you for having me. I'm really excited to have this conversation with you today. And, we'll take people to the kitchen table. I'm from the South. I'm a Southerner. And, I think those are oftentimes the places where the most growth happens. And hopefully we can give people that over the next few minutes or so.
Thank you. Well, Rashawn, I want to start with the question that's personal to me, and I know to you. We've talked about this the last several days. Given the time that we live in and what's happening in this country and what we're talking about today, I want to ask you, when you first became aware that being Black meant that some people look at you or see you differently?
I think that's a great question. I mean, I think I have a lot of examples I could provide. I think the first one that comes to mind was growing up in Atlanta, Georgia. And I was on my way to a baseball game with my mom. It was just my mom and I growing up. She is a registered nurse. So a lot of the kind of information I bring to bear about the way that health collides on people's bodies comes from her. And my grandmother is also a nurse. My wife is a nurse practitioner. So health became something that I couldn't avoid. But as we were going to this baseball game, the street was blocked off. And I was trying to figure out why I didn't want to be late to the game. And I heard my mom say, "Oh, shoot." And I look up and I see some people standing in the street. I thought, okay, maybe it's firefighters collecting money in the middle of the street, which happens. As I get closer, I seen people in all white in white hoods. And I noticed at that moment that it was the Ku Klux Klan that was actually collecting money. So as we got closer to the car, my mother cracked the window and the man said, and he had his hood on and he said, "Hey, do you want to donate to the Klan today?" And my mom said, "No, I don't think I want to do that." And he said, "Okay, well, would you like to join the Klan? Because we need good N-word women like you." And my mom said, "No, I don't think I want to do that either." And we drove off. And rarely even throughout my life had we actually talked about that moment. But as I think about that year, because I also think that was the same year that on the baseball team, I remember making all-stars and I was so excited. And I found out later when I graduated from college that my mom would cry when I would make all-stars in baseball because as a single mom, she now had to pay for another season. She had to figure out how to take off games. Take off from work. She had to figure out how to get me money to be on this all-star team. And I remember this one season, there were 13 players that made the all-stars. 4 of us just happened to be Black. If anyone knows baseball, 9 players start. Well, we started noticing that there were 4 players always late to practice. We found out that the coach, who happened to be white, was not telling the Black players about practice time so that we could purposely be late so that he could start all the white players. This is the reality when it started sinking in, that it wasn't about how good you were. It wasn't about how hard you worked. It was about a system that was in play because while that man who had on that hood was different from the coach, both of them were discriminating and treating my mom and I differently. And then what would happen, I remember on 4th of July, we would go to Stone Mountain. We would see this amazing laser light display. And then I started noticing that the people who we were applauding were Confederate generals on the side of Stone Mountain that would rather my mom and I still be enslaved on a plantation. That was the moments when I started noticing that the system, that how we talk about systemic racism was something broader than simply individuals, but it was a part of a system that allows certain people to gain advantages while other people were disadvantaged.
Rashawn, that's such a powerful story, and thank you for sharing with us. I know that you and I and many others have similar stories, and it's important for us that we are around the kitchen table, the family table conversation, to have the authentic, honest conversations, because it is going to take this kind of conversation to help us heal and get to the real difficult part of what are the solutions, both long-term, short-term, mid-term, and long-term, to get us to a place that we can help reduce and eliminate what these disparities and inequalities are. what you described as racism at individual level and racism at the structural institutional level. We throw these terms around so often, and I want you to help explain to our viewers what we mean when we talk about structural racism or structural inequity. What we're really talking about is equity, inequity in healthcare and in health. What do we mean when we say inequity in this way?
Yeah, so oftentimes people view racism as only operating on an individual level, as you just mentioned. But the way that racism operates primarily is through systems, systemic racism, through what we call in sociology and the social sciences and public health, social institutions. Education is one, the criminal justice system is one, healthcare as a system as another. And what it leads to is even when you don't have an individual racist operating to prevent people from getting something, it's part of a broader system that's baked into our rules, regulations, policies, and laws that lead to one group being disadvantaged relative to another group. And in healthcare, we see that in a lot of ways. I think the best example actually deals with where hospitals are located, where healthcare resources are located. That if you go to predominantly Black and Latino neighborhoods around the country, particularly if they're low income, the lack of healthcare resources is apparent. Not only the lack of healthcare resources, but also the lack of places to engage in physical activity, the lack of high quality grocery stores with fresh fruits and vegetables. And part of, I think, the best example is if we take Washington, D.C., Baltimore, St. Louis, Detroit, Memphis, I mean, the list could go on, and we take a map from 1920 and we overlay it with a map from 2020, what we will see is that the racial composition of neighborhoods, and I've actually examined some of this research, particularly in DC and Baltimore, is what you see is that the neighborhoods and the racial composition look basically the same. Black people in DC are still on the eastern side of the city. They are still primarily concentrated in Southeast. It was that way 100 years ago, it's that way now. And that's because redlining was a policy put in place to legalize racial segregation. Even if we don't have legalized redlining, we have de facto redlining, where what happens now is corporations are looking for places to invest, businesses are looking for places to invest, and they don't invest in predominantly Black neighborhoods. Healthcare places don't invest. If somebody's going to set up a doctor's office, they're not looking at Southeast to do that, even though they should. A new pharmacy doesn't set up there. New parks don't set up there. And it disproportionately impacts people of color.
And how does that, and you beautifully outlined what systemic institutional racism looks like and the equity drawn from that and how it manifests. What is the impact on communities when, as you've described, when there's inequity in healthcare and access and so many others? What does that in a community look like specifically?
Well, I think we only have to look to COVID-19. As we know, Black people as well as Latinos are about 3 times more likely to die from COVID-19. And I think there's a saying that we oftentimes say in the Black community, which is that when America catches a cold, the Black community gets the flu. Well, in 2020, when America catches COVID-19, Black people die. And the reason why Black people die is that our structural conditions undergird pre-existing health conditions. A lack of healthy food options, as I mentioned, a lack of recreational spaces, people living in denser populated areas. So social distancing in that regard really becomes a privilege. Next, Black people and Latinos are more likely to be these new essential workers, these people who are delivering food and dropping off things and working as healthcare aides and custodians so we can order Instacart and make brownies and stay at home with our kids. Oftentimes, those are privileges that we have to be very real about. And then we also have to be real about the lack of healthcare access, which I just described, but then also a lack of healthcare utilization. The reason why that exists is because there's a recent study that came out showing that Black people are 6 times more likely than whites to be turned away from COVID-19 testing and treatment. These are structural conditions before we even get to people's behavior. These are things that are baked into our neighborhoods that systematically discriminate one group versus another.
That's so true. You know as well as I do that at the start of COVID, the belief was that COVID was the great equalizer, that we all die equally from or could be infected and possibly die from it. And then we realized that from the data as we were gathering it, that that wasn't true, right? And as you pointed out, there was a disproportionate impact on people of color, communities of color, vulnerable communities. And then the narrative shifted to, well, these communities, particularly Black people, may not be social distancing, right? That they may not take it enough. The survey data suggested otherwise. Then it came to the narrative changing to, well, it has to be because of pre-existing conditions, right? And then the data and the research revealed just in the last month or so that much greater factors to pre-existing conditions for communities of color being susceptible and impacted by COVID is your socioeconomic status and your employment status and access to healthcare and as you pointed out. So how important is data in helping to draw the insights that we need in order to address the very solutions that I want to get to here in a moment? Because we could see just in a matter of 2 months how the narrative for communities of color and who's shaping that story changed with data.
You know, it is so difficult for the United States of America to admit that racism is a thing. And I think that's the fundamental thing. We keep searching for things when what we're searching for is right in front of our face. And it's interesting because since we're dealing with these two pandemics, COVID-19 and then systemic racism that's been baked into the founding of our country. And it took George Floyd, that 8 minutes and 46 seconds of people seeing that, for now 70% of white people to say, oh yeah, racism is real. Yeah, and that's a good thing that that's being acknowledged. And when it comes to data collection is one of the main solutions that I advocate for, that I've written about at Brookings to help us get past this pandemic. We don't just need to collect race, age, or gender. We need to collect information on place because, as I said, race and place are highly correlated. We need information on pre-existing health conditions. We need to be able to create a map of healthcare resources that people can go to. And part of doing that will then tell us where we need to allocate resources. But you know what else it'll tell us? Not only will it tell us where we're getting things incorrect, data will also tell us where we are getting things correct. And then we can start to model that. See, as a social scientist, I love data because data not only shows us where we need to get better at, but it also tells us where we can replicate things so that we can try to get out of this.
Well, I want to transition our conversation now to at our kitchen table to helping us understand what some of the solutions are. Clearly increasing and gathering more data, but using the data in a way to drive solutions rather than provide us as data has been used often sometimes in the past. I want to look at a question that has just come in, and I want to encourage those as we turn to audience questions now. The last 10 minutes of our conversation that I've asked questions coming in around how do we address the racial divide within and across government?
Yeah, I mean, I think the racial divide within and across government is a big deal. I mean, it's something that I deal with all the time. I try to sit at this nexus. And a lot of it obviously is a political divide between Democrats and Republicans. And honestly, at times, not as much as between liberals and conservatives. And I think it's important for people to grapple with that we have political ideology and then we have political parties. Part of the problem is that we have a very simplistic two-party system in the United States, unlike other countries around the world. So it prevents people who might be liberal or moderate or conservative, very conservative, slightly conservative from having fissures within the political parties. And I think that the way we get past it is with data. I think we get past it with science. Part of the problem right now is that science is under attack. And it's going to take people like people listening to this call to continue to bolster science because science is the pathway forward. Science helps guide us in terms of whether or not we should be opening schools or not. Not just exposing kids to COVID-19, but also exposing the teachers and the administrators, many of whom are in high-risk categories, either because of age or pre-existing health conditions. So I think in the way we deal with this is to continue to have these conversations, but allow science to guide us. And it's very, very important that we do a reset and say, look, this isn't somebody's opinion. This is a reputable research study published in a top academic journal or by a top think tank and organization, and we need to pay attention to it. We shouldn't be arguing about whether or not these are facts. What we should be having a discussion about is how we interpret it and then what we do about it.
Well, as Dr. Fauci often says, let the data drive the decisions that should be made on how we reopen and restart elements or aspects of our economy, right? Let the data drive the decision, how we wish that was true. I want to go to your points on structural inequalities. We can clearly see what's happening now, that there's a broad call for systemic reforms across many sections of our society. So if this time is different, Rashawn, which I know you and I deeply believe, what might this transformation look like in healthcare, both in the short and the mid and the long term? What is it that we can and should do in order to, as our friend the late John Lewis said, cause good trouble?
Yeah, I like causing. I cause a lot of good trouble. And part of thinking about it is short, medium, long-term goals for getting us out of this pandemic. Well, obviously, we're in a great racial awakening. I think in the short term, what needs to happen locally and statewide, there need to be health equity task forces formed. That's important because it's going to center health equity. You made a point earlier about how we approached COVID-19 as if it was an equal opportunity virus, and it is, but our society is far from equitable. Johns Hopkins put together a pandemic response report of nearly 200 countries around the world, found that the United States was number one in finances, but ranked 175th out of 195 on healthcare access. So in order to deal with healthcare access, what we need to do is what Congressman Hakeem Jeffries and Governor Cuomo did in New York. They quickly did this, and I think it made a big change. They started putting testing and triage in predominantly Black and Latino neighborhoods. They primarily used houses of worship. That's one big recommendation I've been having. Use churches that have trust so that you don't have to deal with the trust gap, which is a very rational response for Black people to have. That's one big thing, the trust gap. The next thing that needs to continue to happen is frontline workers need to continue to get hazard pay, and they need to continue to get sick paid leave. That's important because anybody who grew up poor, anybody who grew up working an hourly job and who didn't have health insurance, what they know is that if they don't go to work, they don't get paid. They can't put food on this table, on this virtual table that we're having this conversation at. And so part of what that means is they go to work sick. And when you're going to work sick during a pandemic, not only are you going to probably die, but you're going to probably kill other people as well. We know that Black people and Latinos represent about 30% of transit drivers. They represent about 30% of healthcare aides, of custodial workers. So they are overrepresented. They need hazard pay and sick leave. I think in the medium term, part of what needs to happen, and honestly, I think these are probably medium to long-term goals, but things that we've been talking about for a while that we just need to have the oomph to put in place. We need universal health care. That's a big thing. We also need to ensure that that wages go up. Let's take Nashville, Tennessee. I'm from Murfreesboro, Tennessee, a little bit south of Nashville. The minimum wage in Nashville is less than $9. People can't even work a full-time job and afford an apartment in Nashville, Tennessee. We're not talking about New York or LA or DC. We're talking about Nashville. So part of what has to happen is wages have to increase. And then the other thing we need to ensure that not only that workers get higher wages, but then they also can have a guaranteed income. When you give people a guaranteed income, things start to shift, and then we'll start to see changes in local neighborhoods to invest in those neighborhoods. And I think short and long term, we need corporations and organizations to invest in predominantly Black and Latino neighborhoods, particularly low income neighborhoods, to help build an infrastructure.
Thank you. I want to encourage the audience in our few minutes left to continue to provide questions to Dr. Ray on our kitchen table conversation. John, I want to, in the time that we have remaining, also ask a question about the healthcare workforce. Of course, your wife is a healthcare worker as a nurse. The healthcare system, in my opinion, is not organized or structured in a way to have authentic conversations around race, and I think racial issues, and what I describe as incidents of bias that take place in the healthcare setting, both patients and healthcare workers. As you and your wife know, they know that people of color disproportionately make up that healthcare workforce, as you were just suggesting. And I think as a result, have a higher incidence of bias and also attacks that we've seen reported in the news. What do you think the institutions of healthcare can do to better protect against these biases, both against healthcare workforce, but also the patients that are being served?
Yeah, I mean, as you mentioned, I mean, my wife is on the front lines. I mean, she's a nurse practitioner running her own clinic and is seeing patients come in. And I think the maternal mortality rate and the racial gap in that is probably the most disheartening disparity that we have. That Black mothers who go in what should be the best day of their lives are more likely to die than white mothers. And implicit bias is baked into that. Research shows that medical residents, nurses, physicians, that they have a warped view of race in people's bodies. I mean, they think Black people's blood doesn't coagulate the same. They think Black people's skin is thicker. They think that our pain tolerance is higher. So what I think happens when people deliver babies, they ask you from 1 to 10, how bad is your pain? Two mothers say an 8, but one of them gets the correct amount of medication and the other doesn't, because the perception is that their bodies can take it. And we know from Serena Williams to Beyonce, that this has nothing to do with social class or celebrity when they were almost died. So I think we need to have implicit bias trainings. I think the other thing, we need to ensure that those trainings repeatedly happen. And then we need to have people operate as what I call racial equity advocates and racial equity brokers. On the advocate side, that means speaking up and speaking out when you see something. Going back to that story that I told at the beginning, it would have been nice if the memory I have from that year had have been a white parent speaking up against the coach saying, why are you doing this to the Black players? That's what should have happened as an adult. I mean, I was a kid, but that didn't happen. But that should have been the memory. That's what it means to be a racial equity advocate. It's what Shirley Chisholm called when you're not at the table, you're on the menu and someone's eating you for lunch. And for too long, Black and brown people have been eating for lunch at tables that they should be at the center of. The next thing, we need people to be racial equity brokers. This means if you're a healthcare administrator, a healthcare leader, you need to fully interrogate the rules, policies, procedures, and laws that you have in place and ensure that they are equitable. You need to ensure that people are held accountable for mistreatment, because people are paying attention when they're not. And then you need to ensure that you do satisfaction surveys to ensure that your employees as well as your patients are being treated in equitable ways. Because the difference between equity and equality is important. Equality means giving everybody the same thing, and we know that even that doesn't happen. But equity means giving people what they need. And in this era, when we know that racial disparities are so vast, that oftentimes what people need are different based on race, class, gender, or sexual orientation.
Oh, that's so true. Thank you. In just the minute or so that we have left, there's been questions that come in stemming from our previous conversation. I end with this last question for you: is how do we move beyond what is happening with facts, the visualization of facts overall, and then how do we, outside of the institutions, in our own individual ways, combat and bring down systemic racism and the inequality and the inequity that exists? What can someone do at the individual level, and how do we overcome the politicization of facts? Thank you.
Yeah, I think at the individual level, what can we do? In addition to being racial equity advocates and brokers, I think part of that means not just thinking about who's in office, but holding those people accountable, regardless of what political party they're in. And it also means looking down ballot, paying attention to down ballot, and it means talking to people in between elections in terms of what they would like to see, the types of changes they want to see locally, the types of changes they want to see in their communities. People also need to get more involved in the political process. That can mean serving on different types of committees and being able to play a role in funneling resources. I'll give you a really good example as we close. I did a study with some of my colleagues at Maryland and GW, looking at the impact that school gardens have on academic achievement in Washington, D.C. These are school gardens that the school creates, a little small garden beside the school. What we found is that the placement of those school gardens essentially made the racial and class gap in math and reading between fifth graders completely go away. And people are like, what? Well, think about it. If you're a fifth grader living in Southeast, you've probably never seen a garden before. And if you have, you definitely haven't played a role in it. So being able to get out during school, all of a sudden, it makes your brain go in a different way, and you're learning in a way that can be applicable to standardized tests. So part of what that means is, then after we did that study, we were on a committee to help ensure that school garden funding was allocated equitably across the district. That is an example of how you take research and facts, apply it to policy, and now all of a sudden we have kids in certain parts of the district who are gaining access to resources that kids in Northwest, where I happen to work at by Brookings, have access to in a plethora of types of options, but in Southeast, they don't. So we have to actually put ourselves in the places to be the change and make the change we want to see.
Thank you very much. I think I couldn't agree with you more. We have to be the change that we all want to see within our community, in our lives, and importantly in our society. So I want to thank you, Dr. Ray, Rashawn, for joining us today at the kitchen table conversation. I want to close by thinking about what Rosa Parks said when they asked her in 1955 why she did not get up when she was asked to for the seat. She said, I was just tired and I had enough. And so she sat down so that the rest of us could stand up. And I want to thank you, Dr. Ray, for standing up, and for the Alliance for Health Policy for standing up for fairness, for justice, for inequality, and all the terrific work you and all of your partners do, and for so many, if not all of those who joined us on our conversation today at the kitchen table. I hope that more conversations like that happen in our country. And I thank the Alliance for inviting it to happen. And again, thank you, Dr. Ray, and thank you everyone for joining us today.
Thank you to you, and thanks to the Alliance for the great work they're doing.
Thank you.